Welcome, everyone. Today we're talking with Catharine McDonald. As you come in, feel free to introduce yourself, maybe where you're at in the world and what brings you here. I made sure the chat was enabled for everyone. Welcome, welcome. Yeah, feel free to use the chat. Anyone coming in right now. Let us know where you're at in the world and what brings you here. We'll get started in a minute. All right. All right, so I'll kick us off. Welcome to this webinar entitled Perinatal Trauma or Birth Trauma and Loss for Families. Catharine has been with us before and talked about this subject for providers. And now today we're going to talk and have it focused on families. So welcome, Catharine. It is so good to have you here again. And I'll do a little intro of Catharine. Catharine is a nationally certified in Connecticut licensed professional counselor. She owns Growing Well Counseling in Northern Connecticut, where she specializes in integrative perinatal wellness, fertility and loss, birth trauma, postpartum sexual health, and parental work-life balance. So while completing her graduate training in community counseling at the University of North Carolina in Greensboro, Catharine worked with families on the antenatal unit and NICU in the hospital, the local hospital there. So long interested in reproductive mental health, this experience solidified her passion for perinatal mental health and ultimately led her to helping to create the Connecticut Alliance for Perinatal Mental Health, which would eventually become the Connecticut chapter of Postpartum Support International. Yay, I hear clapping in the background. She has spoken at state and national conferences and creates professional development training for therapists, for birth professionals, and for reproductive healthcare providers on these topics. So also perinatal ethics and clinical documentation and so much more. Catharine has lived and experienced infertility, pregnancy loss, and molar pregnancy. She is also a mom to 4 living children, 3 dogs, and 10 chickens. That's awesome.
Yeah. We have 12 baby chicks too. So I should have updated that for you.
That's amazing.
Chicken math, it adds up quickly. All the babies.
Awesome. Wonderful, wonderful. And as you guys are all coming in, we welcome you, and please introduce yourselves. Tell us where you're at in the world. Tell us what brings you here. And my name is Jennifer Caton, and I work with Return to Zero as a support group facilitator, as a community support advocate, building programs, and really holding space for families. I too am a baby loss mom and have 1 living daughter, a puppy, and no chickens.
The puppy and chickens combo keep things exciting in our backyard, that's for sure. Thank you for that really, really kind welcome. Hi, Carol. Thanks for joining us. I'm so excited to see all these wonderful attendees from all over. Got people from all over the perinatal community. I'm going to share my screen. All right. So today we're going to be talking about birth trauma from the family perspective. And this is something I'm so honored that Return to Zero is letting me speak with you about, because I think it's very under discussed. It's not talked about openly. And oftentimes when there's a different loss, a pregnancy loss, a baby loss, a miscarriage, or stillbirth, the experience that the family goes through is overshadowed by that. And there can be a lot of trauma related to birth or surgical experiences, medical experiences. And we're going to touch on some of those today. Now, before we begin, I do need to say this presentation is educational in nature, does not establish a therapeutic relationship between presenter and any attendees or viewers afterward. It is not a substitute for your own therapy. Anybody who knows me knows I'm a big fan of therapy. It's a very good way to stay well, especially through the challenges of family planning, growing a family, and experiencing and healing from loss. I do want to give everyone a heads up. You probably are here because you have encountered a difficult experience or you work with folks who do. And I think it's important to give you a heads up that there are going to be difficult and at times triggering topics covered, including but not limited to loss, birth trauma, obstetric violence, and trauma symptoms. As Jen said, I am the owner of Growing Well Counseling. My pronouns are she, her. I've been a licensed professional counselor since 2010 and a perinatal therapist for almost all of that time. And as she shared, I have 4 living children. I've had 7 pregnancies and I'm a molar pregnancy survivor. And this picture right here is a little picture of our rainbow announcement after 3 losses. So what is trauma and how we define it in the world of mental health? And at baseline, it's any experience really to be defined by the person experiencing something difficult, where it goes above your coping capacity. We all have kind of a window, a tolerance, and something that overwhelms that ability to cope, creating intense fear, panic, anxiety, or distress. It can be either witnessed or experienced, and it's really critical to highlight that because non-birthing partners, parents who are not pregnant can also experience trauma around a birth experience, a pregnancy loss, or a loss experience. When thinking about birth trauma, I really want to consider everyone in the room. And certain aspects of the birth can be traumatic for the pregnant person, their partner, others attending the birth, the doula, medical providers, and the baby. I see a lot of pelvic or GYN trauma in my work, and many clients are traumatized by the way they are cared for, which I think compounds the trauma of a loss itself. So when I'm thinking about losses in a growing family, these are kind of the bigger categories. An early loss that would be defined by medical professionals as chemical pregnancy represents the loss of what was supposed to be, along with a miscarriage, anything before 20 weeks, where somebody has hopefulness that a pregnancy is going to be okay. Molar pregnancy, whether complete or partial, which has its own medical complications and disruptions to the timeline. Facing a fetal diagnosis and having to make decisions, which potentially might include termination for medical reasons. A stillbirth, a traumatic birth in the process of any of the above, or a traumatic medical experience, a NICU stay, SIDS, and then of course the potential for baby loss. And then I categorize traumas in my practice into 3 big categories. Beyond that trauma of the loss itself, there's reactivated trauma, where something in the past is reactivated, whether it's an experience of abuse, or I've had entirely unrelated traumas. Somebody had a surgery on an unrelated body part that did not go well. They had a lot of pain. They weren't taken seriously. And the experience of going through the medicalization of a loss, a DNC, of repeated GYN visits, or a painful delivery, a C-section, brings that back up. And then unavoidable traumas are things that we couldn't help. What's happening is incredibly upsetting and difficult. And then avoidable traumas are a subspecialty of mine, where how things are handled creates trauma that really didn't need to be there. And this often is a trauma upon trauma. Things were already bad, and this made it worse. My hope in this discussion is to validate and expand acknowledging how many different parts of loss can be traumatic, because oftentimes these are glossed over. Oh, there, you had a pregnancy loss, you lost a baby. Well, what else was lost in there in what we call disenfranchised grief or an abstract loss? So there's the pregnancy itself. There may be partial or entire loss of fertility with an ectopic pregnancy. There's the hopefulness of being pregnant and what those plans were might be for that. And then someone may lose a fallopian tube. There's a cyst or a complication and an ovary is lost, which it feels like a sentence. It's going to be difficult or maybe impossible to get pregnant without medical assistance. Loss of birth choices. A vast majority of people birthing early or unexpectedly and oftentimes going through a loss, their birth plan goes out the window and they're delivering wherever they're told to or where they show up for emergency care. Having a required or necessary C-section can be traumatic for folks. And the journey of family planning and growing your family when impacted by loss and or fertility struggles also can represent the loss or result in the loss of the family constellation that you desired. What was the eventual image, or what was the plan? We wanted a big family. We wanted 3 kids, two kids. And there's the potential for loss of the number of children a family hoped to have. The loss of time is someone getting closer to the end of their fertility journey and or fertility capacity, approaching menopause. Are they dealing with diminished ovarian reserve? And a loss now results in a reset to that clock, and even more time gets lost. And potentially no more children. I've had clients who have a loss coupled with a hysterectomy that saved their life, but that represents the end of carrying children for them. The loss of the baby, a need to terminate, which, while not a forced procedure, can feel like an impossible choice, and conscious choice to terminate out of necessity is incredibly traumatic. Looking back into that reactivated trauma, things can resurface that we didn't think were irrelevant or we were over them. I've had clients who've experienced a car accident, being rushed by ambulance. And the last time they were in an ambulance was when they were in a car accident in high school, for example. It's totally unrelated to a birth experience, but that memory brings up the distress and those feelings. Our body is really wise. Our brain stores those big moments, whether positive or negative, as a reference. So any sort of loss related medical care, bleeding, any emergency can bring up some powerful memories. An assault is something that's not uncommon to be brought up, and suddenly and abruptly being given medical care emergently when there isn't time for good consent or rapport building, when someone needs whoever is available. And there are times when that's not handled as well as it could be. A past traumatic birth, if the loss or the birth trauma is around a subsequent pregnancy, and then those reminders. Unavoidable traumas that are quite common. When things take a quick turn, that can be an unexpected, I'm in a casual prenatal visit, a routine prenatal visit, and all of a sudden I'm being transferred by ambulance from the doctor's office to the hospital. Or someone starts bleeding. The blood loss is often a really powerful visual trauma. Unknowns, will I be okay? This blood looks like a lot. Healthcare providers who are trained to assess blood loss, there's some good research that shows they don't really estimate accurately, and just to an untrained eye, blood loss that isn't necessarily life-threatening can look terrifying. And then there are times when people are at risk, when they have lost too much blood for their health. Urgent procedures, interventions, medical interventions often involving pelvic care, being exposed, feeling vulnerable, and the pain, the physical and emotional pain that come with an unavoidable trauma around birth trauma or a loss-related medical procedure. And then we have avoidable traumas. So this again is how something is done, how things are organized, how care is organized, impacts how someone experiences something as traumatic. Some big subcategories, if you will, are obstetric violence, which is the outward mistreatment, maltreatment, verbal or physical abuse of a pregnant person or a person who has been pregnant. This might include forceful exams, more providers than necessary. Someone doesn't want to be a subject of teaching and students are brought in and someone is told everyone's going to examine the patient and you're the patient. It's not the time. You didn't really want that. I've also seen that happen where somebody is sent to a larger teaching hospital because of the complexity of their case that ultimately results in loss. So they're not only dealing with new providers whom they didn't seek out themselves or choose outside of a crisis, and then there are more strangers, whether it's students or residents. And if the supervising provider doesn't have great bedside manner, doesn't understand loss and emotional wellness, they can inadvertently be training people to have insensitivity, to be poorly equipped to handle the emotional component. And if someone is not great at gaining or obtaining consent themselves, and they're then training people, that leaves pregnant folks and their partners at very high risk of getting inadequate or no consent. We often think when something is medically needed that I have to say yes or agree. The agreeing is the expected default, but it's not actually giving consent unless you were told the pros and cons of something. The risks and benefits are of saying yes or saying no, and it's safe, truly safe, to say no, thank you. Inadequate pain management, when there are some scenarios in which clients who are inducing either a stillbirth or a baby who is going to pass away are very well cared for and nurtured. And there are other instances in which I've experienced people not being given adequate pain management. People are uncomfortable in the labor and delivery ward and avoiding the patient, which is awful because it's ostracizing and devastating enough. And that can also influence or interact with mishandling of the loss itself, talking really medically. You had plans for this baby, this was your baby, there's a nursery plan, there's a registry you're building, and suddenly the medical community is talking about fetal tissue, and the baby you maybe had a name for suddenly doesn't matter to the medical world. And there are these really scientific terms that are being used to keep, it feels like at times, to keep the medical providers comfortable and give them some distance. And then there are more insensitive providers and staff. People are forgetting to notify others or not thinking of the bereaved family. I've had clients charge late cancellation fees for missed appointments after a loss that someone forgot to cancel for them, or mishandling of a loss. I would say also might include having someone get follow-up at sitting in a waiting room with pregnant people, or being on labor and delivery after a loss and having to hear either laboring women or new babies crying. These things can be incredibly traumatic and are entirely avoidable. Some loss and termination specific traumas may include an abortion, whether it's wanted or not, so whether someone feels open to that terminology and insensitive language, a pressure to or lack of choice in termination due to abnormalities. If someone has told you must terminate, it's going to threaten your life. That can be incredibly traumatic. The logistics of these procedures, of any sort of end of life procedure or procedures on baby, it's not uncommon enough, I would say, that clients have had to have repeated or have had incomplete procedures. They need to go back for a repeat D&C, or they have retained tissue, retained placenta. There can be hospital policies in place that don't consider unique circumstances around loss, and there's a one-size-fits-all policy so that everyone in the staff is on the same page at the expense of your emotional experience. Disclosing to family can be traumatic, especially if there are cultural or religious beliefs around termination, around thoughts about, and it can be traumatic to think about, do I have a faith orientation? What does it mean to me? What do I think of happens to a baby who dies or has died? And does that change if I terminate a pregnancy? Relevant dates and anniversaries. In my experience, the entire first year after a loss is a grieving period. You are going through each relevant event for the first time. And the subsequent year won't be easy and nonchalant, but it won't be the first time you go through it. some really prominent or significant dates I typically see are the due date, what would have been the due date. Mother's Day just passed. We're approaching Father's Day. I know this is a really difficult time for intended parents or those who want to be parents, those who are thinking about or waiting for that healthy baby to come into their family and ready to welcome a baby. Holidays, holidays where we gather. There can also be vocational related triggers. If someone works in a school system and they have a loss during the summer, that can be incredibly difficult to then be surrounded by children again, or individuals who earn a living by working with children or babies. I've had healthcare providers who lose a baby, and to make money, they need to continue working. When I had my own losses, I had an entire caseload of pregnant or postpartum people. And the only way I could continue to support my family was to continually support others through pregnancies that were going well or that medically were stable. And that was incredibly difficult. Spoiler alert, I had a great therapist. I have no doubt that she got me through that and allowed me to continue to help, providing great care while I was going through that. Access to care and intersectional disparities. The reality of our country, which does a very terrible job at baseline of caring for pregnant people and birthing people, is that certain folks have better access to care than others. And that may include choice of providers, insurance coverage, time off, likelihood of medical complications, access to transportation, access to go out of state if needed in the context of the current political climate and legislation. There are a lot of compounding potential factors there, and pregnancy complications and maternal and infant death disproportionately affect Black, Indigenous folks, people of color. And so the BIPOC community is disproportionately at risk of not only pregnancy complications, but also complications from medical care. Black folks are disproportionately likely to need an abortion or seek an abortion and to have complications from them. And in the country where nearly about half the states right now are restricting or have entirely eliminated termination care, even where there are exceptions or alleged exceptions, it's really murky, and it's very likely that they would need to travel to get the medical care that they need. And that adds to the trauma and stigma around that. So in this post-Dobbs era, we've got a lot of state and legal specific considerations that compound and amplify the cultural considerations and what kind of support emotionally someone will or won't get, how safe it is to speak about what's needed, and access to care. Does somebody have access to a provider they can trust? Do they have the means to get there, or insurance coverage? And some of this post-Dobbs legislation, there are individuals who do not have insurance coverage anymore. Some insurance plans are allowed to discontinue coverage of certain procedures. And many of you know there's a fight over medication abortion coverage right now. So when someone is faced with a termination decision, facing an imminent loss, these factors just amplify and compound the trauma. There are also people who very realistically fear being able to have an open conversation with their doctor in certain states. Can they trust their doctor to give them medically accurate information? And you're already traumatized, terrified in this sort of surreal experience. I don't know what's happening. I cannot believe this is happening. And I need to think critically about this. Am I getting information from someone who I can trust? Are they going to tell me somewhere safe to go? Do they know where to go? There's an understandable fear of criminalization, and it's also hard to keep up with the legislation that's rapidly changing. I'm following several reproductive rights activists right now, and it seems every day the landscape is changing. So at baseline, I'm thinking about what does it mean for someone to be considering termination? Are they alone navigating this devastating crisis? How does their culture and religion influence how safe it is to talk to anyone? Is there any support that's safe? So these barriers are going to continue to make it difficult and add to those traumas. Thanks, Jennifer, for taking that question in the chat. So the changing legislation and all of these different factors influence how likely or at risk someone is of trauma. And then when we add those avoidable traumas on there, someone has to travel, they've got to figure out childcare for a child at home, pay out of pocket or apply for financial support. There's some great organizations providing financial support. And then they may not get sensitive care, or they don't know anyone there. Maybe there's trauma around male providers and the only option is to see a male provider. There's so many little subtle things and they add up in this crisis. So if I leave families who've experienced loss and trauma intersecting with one thing today, the most important thing I could tell you is that it is not your fault. There is nothing that you could have done. There is nothing that you did wrong. And you can't help that your pregnancy required or resulted in a loss. And you can't change. I firmly believe that nothing is a make or break. You couldn't choose to grow an unhealthy baby. If you could choose to grow a healthy one. You can't choose to keep a baby who has passed alive at any stage of this process. You also can't tell that a provider might perpetuate trauma. No one advertises, I am very insensitive and I have terrible bedside manner. I'm probably not going to be the best person around if things go wrong. You don't get that sort of transparency or self-reflection in a provider who's harming patients intentionally or unintentionally. I would say callously or unintentionally. I don't think often the vast majority of the time, it's not malicious, but there's a carelessness about it that results in harm coming to the patient. If you are facing a potential loss, there are some things you can do to advocate, and there are some things you can do to advocate with healthcare going forward. If you're at any crossroads, any decision-making point, it can feel rushed. Your mind is flooded. It may feel like there's limited time with a provider. Gather your thoughts, pause, take your time. It's okay to speak up, and here's some sample language that you might use. Excuse me, I need a moment. Please hold on, slow down. I'm gonna need you to re-explain this. If someone is alone getting medical care and they're feeling overwhelmed or flooded, it's okay to stop and say, please wait. I need to call someone, put them on speakerphone, ask, can you please take some notes from here? Can you listen to this with me so we can talk about it later? In the moment, it can feel like you're a deer in the headlights, frozen, don't know what's happening. That's a trauma response. So it's entirely appropriate to say, slow down, let's go over that again. The door doesn't close when the literal door closes. If you go home after getting bad news or a scary, upsetting, traumatic update, it's entirely appropriate to call the office that night, the next day, and say, I need to revisit this. Please re-explain. If you're feeling pressured to make a decision, I've had many clients in an ultrasound told, you need to do X, Y, Z. That's a lot to take in. It is appropriate and perfectly fine to say, I need time to think about this. I'm not ready to make a decision today. And also to ask for more information. You should, whatever it is, something I know that some providers have told clients. According to whom? Why? It's okay to ask those questions. It's okay to hold a provider accountable and say, what are the pros and cons of what you're recommending? What are the pros and cons of not? Are the risks and benefits equally relevant? You might also, informed consent is one of those buzzwords that can perk up ears and get attention in a healthcare setting. I'm going to need more information to give informed consent to this. Will pretty readily stop a provider in their tracks. If it doesn't, big red flag, time for a second opinion. But much of the time saying, I need more information before I can give informed consent creates a cue to stop, pause, and slow down with you. It's very appropriate when you're making literal life or death decisions or quality of life influencing decisions for the birthing person or the baby to say, I want to wait and get a second opinion. that might be within the same office. You might feel better going elsewhere. In Connecticut, we're not too far from Boston Children's, so it's not uncommon for families to go up there. In California, there are some phenomenal major hospitals. And many of the larger hospital hubs that are connected to major medical schools have consultation service. It's built in, it's very well orchestrated. And so they have a system set up for consultations. If you're seeing a maternal fetal medicine specialist, they probably are used to that and they know the process and can send your records over. If you are in a procedure, feeling overwhelmed or activated, feeling that things are too much, you can request that any non-essential or non-vital providers leave the room. I understand this is a teaching hospital and this is too much right now. I need anyone who doesn't need to be here to leave. And people often don't know they have the ability to do that. Sometimes at teaching facilities, things are presented as, this is a teaching hospital, you have to have students. But you may not consent to having students as you're navigating this really difficult trauma, and that's okay. If you need to be hospitalized inpatient on a medical floor, you may ask to be placed away from maternity or the nursery. Even if you need care in obstetrics, can you recover somewhere quieter? And then calling ahead to the OB office is a way to advocate. If you need post-procedure or post-birth care, can you call ahead and say, I'm going to wait in my car. Can you call me when an exam room is ready? Or I would prefer not to wait in the exam room until I can go into an exam room. I'm not going to be sitting in your waiting room today. And this is something beautiful that a loved one, a family member, a friend could do for you. So if this feels too hard for you, or if you are a friend of someone who is bereaved or recently had a traumatic loss, you can say, can I call for you? Or if you are grieving as a family, you can ask a friend, a loved one to call and say, hey, so-and-so is coming in on Tuesday at 10. They just had this loss. Can you make sure everyone knows and that they're not sitting in the waiting room with other pregnant folks? So that is something that's appropriate to ask for. These are all appropriate things that I've had clients do in the past and that I've talked to healthcare providers about. If someone pushes back on any of these, that's a big flag for me. There are no outrageous requests here. What if I was mistreated? What if you look back, and it might be in the moment, what is going on here? It might be the next day, or weeks later, as you're processing with someone. I've had clients a month or more out of the loss in therapies. That is not okay. I'm not okay with how, as I'm processing this, I'm not okay with how that happened. So you have a few options. There are a few things that you can do. Would it help to have a conversation with the provider? Would it give you some closure? Might it help to get your questions answered if you felt like things weren't explained well, or you just want to ask for reassurance? This also might be influenced by, do you plan to go back to that person? Sometimes when people receive traumatic care, they come to me and they're not going somewhere. They are not going back there. I will not set foot in that office again. I can't go back to that hospital. And that's fine. That's entirely appropriate. Then I want you to transfer care. The last thing I want is for someone to not get preventive and follow-up care because of a traumatic experience. So if you are going to transfer care, go somewhere else where you don't need to see, reduce as many triggers as you can. Go somewhere else, call and say, I had a recent traumatic loss. I need follow-up care. I need whatever the care is. I need post-op care. I need someone to look at a scar or a healing wound. I need someone to do my annual exam, or I'd like to talk to a provider about transition care. You may do multiple of these also. You might choose to give feedback. You might call an office manager or ask to have them call you, or call patient relations at the hospital or a surgical center. You can ask someone to document your complaint formally. If things went very poorly and you think intentional malpractice or mistreatment happened, if something went, whether unintentional or not, something went very wrong, you may choose to take things further. You can report to the state medical licensing board. You can request an investigation. And I am not going to tell anyone to take or not take legal action, but there are some times or scenarios in which people choose to seek out an attorney and review if there's a malpractice component to that. But on your own time, that's your choice. That's something you would want to decide. And my big focus is for you to make sure you're getting your care, that you're not neglecting healthcare because of how things went. Sometimes clients find it very helpful to go to a new provider, not because their provider was terrible, but they just don't want to be back there. You also might consider going to a smaller practice. Sometimes that can help, to go to fewer providers. I've had a lot of clients have very good luck with some of the midwives in my community who schedule longer appointments and sit and listen. And that listening is so incredibly valuable right now. So what is next? You're going to want to find a trusted provider, ask for a pants-on consultation. You can use that phrasing, or just a non-visit. I would like to have a non-medical visit. You want to make sure that you have accurate information, that things are healing physically, not just absence of a raging infection, but that things are going in the direction that they are supposed to for your unique circumstances. Then think about how you're going to take care of your mind and your body. I love acupuncture after any sort of medical trauma because they don't have to get entirely undressed, and it can feel really, in addition to the benefits of acupuncture, it can feel very good to get comforting care, to be a patient and not have to disrobe, to be a patient and to just feel cared for without things going wrong, without getting a big update. And acupuncture has some good evidence that it can be supportive of cycle regulation, egg quality, anxiety. It can improve sleep. Sleep can be tremendously disrupted in times of trauma. And overall, it can be really beautifully beneficial. Integrative medicine, under that umbrella, I put acupuncture under there, as well as naturopathic physicians, talk therapy, physical therapy if it's helpful, pelvic floor physical therapy can be helpful if there was trauma to the pelvic floor, and nutritional support to help your mind and body heal from everything you went through, probably feeling really depleted after a loss. And then the next priority that I want to share is to not judge yourself. This grief is an ongoing multi-layered process, and it's not linear. It's not just a check the boxes 1, 2, 3, but grief is kind of a tornado. There are these gusts of wind that pull you in, and then there will be moments where it feels a little calmer. And so trauma is going to complicate that. Trauma is kind of like the lightning around a tornado. You're not really sure which direction to run for shelter. And it may feel like there's nowhere that feels safe. So helping your body feel calm and cared for and get back to a place where you feel safe and your whole nervous system can calm down and regulate is essential for then doing the deeper healing after a loss. Healing is going to look like multiple steps. So there's that self-care, not commodified self-care, manicures and massages, which are also valuable, have a time and a place, but really taking care of things that are familiar and comforting. Maybe a playlist from college or from your teen years, listening to music that feels comforting and familiar. Having other safe comforts, your favorite tea, favorite pillow, essential oils if you like them, anything that feels familiar. Maybe it's a favorite candle. Nourishment, warming meals can have many cultural, historical documentations of being very healing and helping the body and blood flow restore. So I'm thinking about an integrative perspective and just healing the whole body. Having connection is essential. Talking about what you went through in therapy. I highly recommend you find a perinatal trained therapist. Return to Zero has some wonderful resources, as well as Postpartum Support International. You want someone, excuse me, who understands the magnitude of a perinatal loss. And by perinatal, I mean in pregnancy or the postpartum. You want that loss support, someone who's going to validate and acknowledge all of the many abstract and real visible losses that we've seen today. Healing in your relationship with your partner. You want to lean in and listen, hear each other's experiences and not hide from your partner. Even if it's hard for everybody, and your partner knows it's hard. You don't need to hide when you're struggling. Your partner, I'm sure, knows that you are grieving and that you're having a rough time. Listen to how your partner is grieving and honor that you will grieve differently. a lot of times couples who've experienced a traumatic loss worry, are we gonna be okay? Are we gonna get through this? And the most successful healing in terms of the relationship health that I see is when people acknowledge and accept they're grieving differently than me, and that's okay. I just want to make sure they're still moving forward. So you don't have to grieve identical to me. You just need to be dealing with your feelings, not trying to stuff them down. And then finding connection. Families who understand, that may be through support groups like the ones that Return to Zero offers, peer supports. Postpartum Support International has some support groups. There are retreats, virtual and in person, places where you can go and be reminded that you are not alone, that you're not the only person this has happened to, and where you can hear others talking about what was difficult for them. So there's some really wonderful things that you can do in terms of taking care of you. And this is a process. This is not a checkbox, check all these 4 boxes and then we're done. But these are a collaboration of efforts to help your mind and your body heal when you have experienced trauma and loss. Some people think, I think I'm doing okay. I'm not sure that I need to necessarily go to therapy. And that may be the case for some. I'm biased, but I think everybody who's had a loss or any trauma benefits from talking through that. There are some more noticeable signs that therapy might be more essential or critical. And these symptoms are ongoing. They're kind of the theme of the week, not just here and there. I didn't feel like breakfast this morning, but I ate the rest of the day. But a low mood that persists pretty much throughout the day, loss of interest, poor sleep. That could mean difficulty falling asleep, staying asleep, nightmares, night waking, waking up early in the morning and not being able to get back to sleep. A change in appetite either way. So comfort eating, seeking comfort food, or not having any appetite whatsoever, missing meals. I'm not even hungry. Nothing feels appetizing. Tearfulness, anger and agitation. Sometimes there can be anger at the world, the partner, the healthcare provider that rises to this agitated level. You're snapping, wanting to throw something or actually throwing something. Having difficulty bonding, whether that's with a surviving sibling of a lost baby, with your partner through the loss, difficulty feeling attached to living children or family members who are supportive and trying to help. Thoughts of death and dying of yourself, thoughts of experiencing thoughts of suicide or thoughts of wanting to be with the baby who has passed, thoughts of being worthless and I can't do this, what's the point? That's a big red flag that therapy is needed as soon as possible. Panic, obsessive worry, even if a provider is reassuring, there could be fear of hemorrhaging again, really intense thoughts going back to the experience, fear of a subsequent pregnancy or subsequent complications in a pregnancy. Hypervigilance, this often occurs around health. It's not uncommon to experience that related to health. I think I felt something again. I've had clients who've had a loss and a medical complication and they continually feel like that's replaying, and the body can be very tricky. So you might have physical sensations that feel like that. Heart racing goes right in line with panic. Intrusive, unwanted thoughts, vivid replaying can kind of go hand in hand with flashbacks here, and thinking about what could happen, or maybe they're kind of more distantly related. I lost a baby and now I'm convinced that my toddler is going to die, that something terrible will happen. I've lost one, I'm going to lose the other child. And there's really no logical, specific connection necessarily, but it feels very real in the moment. Racing thoughts, I can't concentrate at work, I can't follow a conversation, my mind is just taking off. Restlessness that feels disruptive, not just an occasional tossing and turning, but really feeling like you can't sit still, that you can't concentrate, or is impacting sleep. If there are living children or a subsequent pregnancy, checking obsessively, maybe getting a Doppler at home, wanting extra visits and they're not reassuring, asking for extra medically unnecessary ultrasounds, or if there's a child in the home, checking excessively on them, getting extra monitors, fixating on multiple monitoring devices and going beyond a general checking in. Flashbacks are very common, especially around medical trauma, and these can be multisensory. So that might look like the visual images, thinking back, it looks like a photograph or it looks like a video playing. It also could be sound, auditory. I had clients who have auditory flashbacks. They hear that the hand sanitizer pump, that crunch click. They hear the alarms going off, the codes being called, the echoing of codes and alarms in a hospital feel very clinical, or it can be of the heartbeat, hearing that really loud whooshing heartbeat from an ultrasound machine. Nightmares can have themes, or they can just be unrelated nightmares. Just poor sleep is a good sign that therapy could be helpful. And feeling detached from your own body, feeling disconnected from your own body or from others, having a sense that you don't feel connected, that you can't connect, no one understands, it can be a disgust and detachment from the body. I'm mad at my body. I don't want to think about what happened and trying to push that away. And so any of these symptoms can be a really good signal that perinatal therapists specifically would be helpful. And then some of that is also time, that this is not something that's going to be fixed overnight. While medication may be helpful and useful in some cases, that's also not going to fix things. And that setting expectations that it's going to take time can help you give yourself compassion and be realistic that we're going to need to take time to work through this worry, this grief, this trauma, this sadness, and normalizing that. And that's difficult and isolating for bereaved parents, because oftentimes the rest of the world has forgotten about the trauma or the loss, or it's easier for those not directly involved to move forward. And we've lost your baby, or that baby's parent, and you're struggling to find ways to meaningfully parent them now that they're gone. So it is not a simple task, and you want to be compassionate. Give yourself compassion and love as you try to gently navigate the healing process. And that's what I have for you. I would love to hear from the audience and take any questions. I'm going to stop sharing my screen now.
I think there was one question on the last slide for signs and symptoms that Ashley lifted up about anxiety isn't on there, or what that looks like.
Yeah, Ashley, I listed a bunch of symptoms of anxiety, but didn't name it specifically. So thanks for sharing that reflection here. I think about that. I'm looking at those symptoms of anxiety, and that poor sleep and panic, or isolation, the hypervigilance, obsessive worry. Those are so many different symptoms that can happen with anxiety. And for some individuals, it can help to name it and say that is generalized anxiety disorder. And for others, it can feel pathologizing. And so I'll take an approach of talking about the symptoms and what's impacting functioning and quality of life. But absolutely, those are clinical symptoms that list the right side was clinical symptoms of anxiety. And the nightmares can be a symptom of either anxiety or depression. But anxiety and depression coexist. They're kind of like roommates. They're often as a mix of the two. Yeah. So yes, Joey, thank you so much for sharing the feedback. And if there's someone who would benefit from seeing this webinar, it will be up on the Return to Zero YouTube channel. And I hope it is helpful for other folks. There are so many different types of traumas associated with loss that just get glossed over or brushed past. And it's important for us to name them and acknowledge them.
Yeah, I want to echo that, Catherine, that having lived through it, I've had 6 pregnancies and 5 of them being losses, including early miscarriage, second trimester losses, and a stillbirth of our son unexpectedly. And I don't think I realized or even had a concept or understanding that what I went through was trauma. My nervous system was overwhelmed, flooded, couldn't process what was happening in the moment. And I'm learning about it now, holding space for other families. I'm now truly understanding how our bodies work, our nervous systems. And I think that's the biggest message you're getting across here, is that this is trauma. Even if it's something society sweeps under the rug or doesn't acknowledge, we're talking about it. Return to Zero, we're breaking silence. We are going to break this down. We have language around it, especially for parents who are going through it. There's just big emotions and a lack of language, but thank you so much for lifting up and acknowledging and hopefully making people feel validated in their lived experience with this. Yeah.
Thank you. And something I didn't include on the slides is that you just made me think of in your sharing about your losses is what I call emotional math. So after my molar pregnancy, it was my molar pregnancy was a 1 in 2,000 likelihood that would have happened. And everyone in the medical community with good intentions kept saying, it's a 1 to 2% chance of recurrence. It's like, everything's going to be fine. 98% chance it'll be fine. And in my mind, in my heart, I thought, I've been the 1 in 1,000. How on earth could I not be 1 in 2? And it's so important to separate those pregnancies and say, there's trauma here. The trauma is telling me emotional math. It's impossible things could go well, right? And thankfully to some degree, pregnancy is somewhat of a passive experience. So I don't have to believe that it's going to go well. Either it is or it isn't. And sometimes we tolerate a subsequent pregnancy. You have to just get through it. You show up and get your prenatal care. You follow medical advice from your trusted provider. But sometimes emotionally, we're just not going to get there. And the pregnancy is a means to a baby, right? Yeah. Ashley, that bad luck and being on the wrong side of statistics is so crushing. And sometimes I talk to clients about, I'll hold the hope for you. You don't need to be optimistic. You just need to go through the motions, and compartmentalizing can sometimes help people get through it and weather it. And I will say that I had grief around that too. I still grieve and I feel sadness about the loss of the ability to enjoy my pregnancy with my finally rainbow baby. I was sad that I didn't like it. I was tolerating it. I talked in my own therapy about getting through it. And when I knew that I was far enough along that baby would be okay on the outside, I was like, okay, come on, like, let's get it over with. I need to see this baby. I need to know they're okay. And the medical community isn't always being aware of that or paying attention to that process. And well-meaning sensitive providers may need those reminders, which brings me to Jamie's question. Any tips or ideas to communicate with providers who may be causing harm to their patients, but don't take constructive feedback well? If the patient has the means to transfer providers, if there's an option to go to another practice, I would absolutely invite them to consider that. And I invite clients who have the ability to consider interviewing a second provider, so that if they do stay where they are, they've stayed by active choice, not by default. And I try to build positive relationships with people who provide very good trauma-informed care. There are a few OB and midwife practices in the community where I can call a provider and say, I know you don't usually take transfers at 20 weeks, but will you meet with this patient and see if they're appropriate? And building those relationships gives me a little bit of leverage to advocate. Additionally, as a provider, a perinatal therapist, I'll send a letter, a treatment summary, or a collaborative letter. And when you send medical documentation, that has to be become part of the record. So there's a degree of obligation for the healthcare provider to acknowledge it, put it in the record. And I'll always send the client a copy too, so that they know what I sent over, and that can help them form a conversation. And on more than one occasion, I've had clients say, don't undress before that visit. You sit there on that table until you talk about the letter I sent over. And we shake things up a little bit. And sometimes providers need us to disrupt their schedule or how they do it here to help the client avoid excess trauma or avoidable trauma. And so in my treatment summary, I might say, these are some examples of things that could be difficult or traumatic for the client. And these are some suggestions that I think would help their mental health in this pregnancy, which in turn impacts the physical health of the pregnancy. Family planning after trauma is hard, and trying not to just replace the baby that has passed. How do you navigate this? I think that honoring all the babies that you have had in a way that feels meaningful to you, and there isn't a right answer to that because it's unique for everybody. Some people that's more inward and private, and for others, they want their baby's name to be said. They want their baby to be remembered by others. I recently had a client have a ceremony of a celebration of life for their baby who passed after a very short stay in the NICU. And that there were different customs and cultures, and just honoring and inviting people to use that baby's name, gathering together and for the purpose of that baby is a way to parent a baby who has passed. And in terms of a subsequent baby, acknowledging, I like to think about items that may have been given to or purchased for a prior baby being hand-me-downs. We're not replacing that baby, but this is their siblings' hand-me-downs. And there are some beautiful books out there. There's a book called Someone Came Before You. And as a therapist, I keep some loss focused books in my office so that people who want to can poke around and look at them before they buy them, or they may not want to keep them. And some people really love those books. I'm blanking on the author, but the person who wrote Someone Came Before You also wrote We Were Going to Have a Baby, but We Had an Angel Instead. And there's also a book called Something Happened that is for helping children talk about loss and keeping mementos, visuals around the home. If you've got pictures of living children, having either Now I Lay Me Down to Sleep pictures of the baby or mementos of the baby, footprints, if you're able to get those, and so that all the babies are represented. I once had a client ask everyone who was saying, what can I do? What can I do? To send them, it was around the holidays, and they asked if they could send an ornament for the baby, and they made a little tree in the nursery with ornaments for that baby. So the baby had a tree of beautiful little ornaments that had different symbols and meanings related to nicknames or funny, happy moments that had been talked about the pregnancy. So there's no one right or wrong way. And I think that it's a journey that might evolve too. And it depends on what your resources are, what feels special to you, what plans you had for the baby, and how can you adapt those plans to continue on in meaningful ways.
Thank you, Catherine. Yeah, it's really important for families to hear that, to be given permission to be creative in how they incorporate their baby's life into their family going forward. Because in my own experience, James was my first full-term pregnancy that ended unexpectedly in his stillbirth. And it's been a beautiful, over the years, finding ways to integrate him into our lives throughout the year, on his birthday, throughout Christmas. And now we have a living daughter who's 5, and she talks about her brother who died. And yeah, it might be uncomfortable for some people, but that's our truth and that's our story. And he changed our lives forever. Yeah.
I would say that discomfort is avoiding discomfort is a privilege, and your family has been touched by traumatic loss, and it's okay to not quiet that to keep others comfortable, because losing a baby is traumatic and it's uncomfortable, and James deserves to have his story told.
Right. Well said. Yeah, they do speak their need to parent that child even in death. Absolutely, because we have love to give, and we lost the opportunity to love all over that child, that living child. The love does not disappear, but we do need a place to put it. Yeah.
Thanks so much for having me. I hope this was informative. I'm happy to answer questions. And if you're not watching this live, my email address is on that last slide, and you can also connect to me through Return to Zero. I'm always happy to connect with families and providers and see how I can help you.
Wonderful. And here, I'll put it in the chat too, just for now. Great. Thank you everyone for attending live and those who watched online. And Catherine, it's awesome to see you again. Yes.
Good to see you too.
Take care, and we'll talk soon, I'm sure.
Sounds good. Have a great day, everyone.
Welcome, everyone.